I feel like I need to do this. It's been a long night, and I feel like we are really finding it harder to breathe, just as Maroon 5 did in 2004.
That's the one you picked? You didn't want to go with your Destiny's Child?
Well, we did lose our breath too, so.
Oh, God, I love Destiny's Child.
They're wonderful.
So good.
The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect official policy or position of any entity, aside from possibly Cashback Memorial Hospital and affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong.
And welcome back to Curbsiders. I'm Dr. Moni Amin, joined by my lovely co-host, Dr. Meredith Elizabeth Trubeth. How are you doing this evening?
Doing pretty well. How are you?
You're holding up, girl.
I am, barely.
Well, on tonight's show, we have a great conversation about acute exacerbations of COPD with our guest, Dr. Jim O'Brien. And in just a minute, Dr. Cyrus Askin's going to tell you a little bit more about our guest. But in the meantime, Meredith, will you please let the good people in the audience know what this show is about?
Sure, Moni, I'd love to. We are the internal medicine podcast. We use expert interviews to bring you clinical pearls and practice-changing knowledge.
Awesome. Well, happy to be here on air with both of you, and happy to welcome our guest, Dr. Jim O'Brien, with whom we had a great conversation about acute exacerbations of COPD. So Dr. O'Brien is a graduate of the University of Minnesota Medical School. He did an internal medicine residency at Hennepin County Medical Center in Minneapolis. Then he went on to do a pulmonary fellowship at NYU, followed by a critical care fellowship at Stanford. Dr. O'Brien's practiced pulmonary and critical care for about 15 years in the Seattle area before returning to academics at National Jewish Health in Denver. And he's practiced for about 30 or more years at this point, so a wealth of experience. In addition to continuing to see pulmonary and critical care patients, Dr. O'Brien has been part of the COPD group at National Jewish since 2013. So we are super excited to have this expert in the field with us tonight, and we cannot wait to dive in.
Hi, Jim. Thanks for coming on the show. Cyrus, can you take us to our first case from Cashlack?
I would love to. Our case coming from Cashlack Memorial. So you are working at a nearby safety net hospital affiliated with Cashlack Memorial, and you're called to the emergency department to evaluate Ms. Natalie Harrison. The ED physician tells you that Ms. Harrison is a 56-year-old female with an extensive smoking history who presented with shortness of breath. She started smoking at age 16 and has averaged 2 to 3 packs per day since then. Unfortunately, over the last year, she's fallen on hard times and finds herself undomiciled, moving from shelter to shelter as needed. Over the last 3 to 4 days, she's felt feverish, noticed worsening cough, which of note is productive of copious sputum, and overall endorses easy fatigability and malaise in addition to her dyspnea. Ms. Harrison has never had health insurance and does not take any medications. However, she had been seen intermittently at a local free clinic where a volunteer pulmonologist did some breathing tests and diagnosed her with chronic bronchitis. So, Jim, as you're listening to the patient's presentation, I guess to sort of open things up, what elements of her history are immediately concerning, and what other information might be worth obtaining prior to your face-to-face evaluation, while you're kind of on the phone thinking through what you might want to do for this patient?
Right. So I would say that the important things, in addition to the dyspnea and cough and et cetera, would be the fact that she has fever, making a mere acute exacerbation of COPD or even bronchitis, maybe less likely, and more likely she may have pneumonia or some other more infectious inflammatory process going on. I think the fact that she has copious sputum is helpful in making some decisions down the road about antibiotic therapy. And in addition, if I was getting a call from a hospitalist about this, I'd ask her BMI, because that would be important given information that's coming down the road about whether, where she should be sent in the hospital or disposition. and how concerned we may want to be with, in particular, her arterial blood gas. So that would be an important piece of information to me.
Can you elaborate specifically on that? The BMI element isn't something I routinely think about, except in the sense that like a lot of my patients who have advanced COPD are cachectic often because of their COPD. Can you talk a little bit more about that?
Yeah, I can. There's the traditional monikers of, a pink puffer and a blue bloater. The pink puffer is somebody who has, hypoxemia assessment intact in their brainstem, and they will work to keep their oxygen level and their CO2 level. Their CO2 response is high as well. And they do that at the loss of musculature. Somebody who is a blue bloater usually is overweight and just doesn't give a hoot about what their carbon dioxide and their oxygen are. And that usually evolves out of having sleep apnea and having changes occur in bicarb levels in CSF and affects the brainstem over time to limit CO2 and hypoxemia response. So if the blood gas is poor, I get less worried about somebody who is obese or overweight and a blue bloater than I do in somebody who is a pink puffer, who doesn't really have much reserve when it comes to musculature and breathing capacity. So yeah, I'll leave it at that.
I see. And I know we talked a little bit. You mentioned the fever, and she has these subjective fevers. We'll get later in the case, and we'll get a little more information on that front. But certainly that's something that could point you in one direction or another. And then I think you'd mentioned the copious sputum, the cough. That's something that's kind of worrisome, and maybe leaning you perhaps in the direction of a COPD exacerbation, depending on some of the other things you're finding. Is that accurate?
Yes.
Okay.
I would say, first of all, COPD being highly prevalent in smokers, it's also highly prevalent in those of lower socioeconomic status, and her being undomiciled is going to create like a pre-test suspicion in my mind. The fact that she was diagnosed with chronic bronchitis prior to this is also helpful in sending me down a track of thinking something related to COPD. Now, when it comes to bronchitis versus pneumonia relative to a fever, usually chronic bronchitis doesn't cause fever. So I think less of just chronic bronchitis when I hear somebody has a fever and a white count, and down the road, I guess we would know that.
Excellent. Okay.
I think, I'm going to jump in for a second. I think that you also were just like, in the couple of answers you've given, already referencing also like their blood gas being an important variable for you. Could we maybe, because I think so far, like what are kind of the other important indications early on? Blood gas, O2, are those sort of like, can you walk us through what are the important initial things you're asking for?
Sure. Yeah. So vital signs would be important. And with vital signs, I would ask for the BMI as well. We report those with our vital signs here. And then, oxygen saturation is something that we can do immediately. And depending on what that is, understanding what their supplemental oxygen needs are going to be, or what they are if they've already got supplemental oxygen. Then, exam would be important, and I'd probably ask if they're wheezing or not. It may be helpful in a diagnosis. If she has wheezing, it may suggest that she has a component of asthma in addition to COPD. I don't think you can get a great cardiac exam in a noisy emergency department. So, the idea of a new murmur or something, I wouldn't depend on. And then I think of labs, and the labs that I would want would be a full basic metabolic panel so that I can get an anion gap and an ABG. I would also want to know about the CBC, given the, wanting to understand her white count and her anemia status, etc. But I think the most important labs are going to be the ABG and an anion gap. And then I'd want to know what a chest radiograph looked like.
And you mentioned ABG. Sorry. So are you...
okay. VBG would be fine too.
Okay.
I'm going to ask one more question before we go on to something else. But so for her, I think Cyrus is sort of painting like a nice picture of COPD, but and so we've kind of gone down like her need for like a chest x-ray. But certainly, I don't know that everyone would come in quite so black and white. And so certainly could be thinking of a broader differential. And is there certain times where you might be more prone to wanting to do like a CT chest, or kind of what helps you decide that?
So, I think somebody with known COPD who presents to an emergency department, there is a broader differential than just a COPD exacerbation, obviously. And in this case, pneumonia is one. But this is something that I think most of us know, is that, pulmonary emboli are common in people who present to hospitals with an acute exacerbation of COPD. Some literature, 15 to 20% of those that present to emergency departments have evidence of a pulmonary embolus. Now, a pulmonary embolus may be there in a subsegmental aspect, and that may not mean that the pulmonary embolus triggered their acute exacerbation. But PE is something that one would have to consider. Others, would include congestive heart failure, or in this case, I would wonder, about somebody having bacterial endocarditis and, having valvular dysfunction or throwing emboli. I would also then, consider what else could we throw in there? We'd throw in pleural effusions, pneumothorax. Can I say one more thing about the role of a D-dimer in this setting? Because I would be inclined just to get a CT angiogram on her in the emergency department, and I wouldn't depend on a D-dimer. There is some data to suggest that D-dimers are elevated in patients with having acute COPD exacerbations without evidence of pulmonary embolus. So if you have a negative D-dimer in this setting, again, like the CRP, I would probably consider it a spurious lab. And then if it's positive, you move on to your next diagnostic regimen, which is a chest CT angiogram.
Well, so I think probably moving on with the case, so we can get to the meat and potatoes here. So unfortunately, this patient doesn't have any history in the medical record, so you don't really have anything to reference. And as we stated earlier, cash lack, paper charts, who knows where the records are anyway. But you do have some initial labs and some imaging. So the CBC gives you a white count of 17, some mild anemia, thrombocytosis. BMP is notable for mild hyponatremia at 128, a bicarb at 34, a creatinine at 13, a BUN of 47, and a lactate that's modestly elevated at 27. Patient has a venous blood gas that's drawn. The pH there is 7.25 on the venous gas with a PCO2 of 77. A D-dimer was also drawn, and it's modestly elevated. Cardiac enzymes and BNP were obtained. They are within normal limits. Chest x-ray was obtained, notable for hyperinflation, but no evidence of a lobar process and no other findings there that were mentioned. At this time, no CT has been obtained. And then finally, the ED physician tells you that the patient's alert, awake, and oriented, but does appear a bit tired. Other labs that were obtained include blood culture, sputum culture, and then a respiratory viral panel, which is pending as well. So with that, you arrive to the ED, you see Ms. Harrison and review her vitals. She's currently on 6 liters nasal cannula. Her SAT is 89%. She's hypertensive and mildly tachycardic. And you do note that despite her concerns regarding fever, she actually is and has been normothermic in the ER. So felt feverish, but no fevers. So that's a lot of information, I know. So I guess just an open-ended question is based on that information, are there any labs or RADs that stick out to you and help you sort of fill in your illness script for what's going on with this patient?
Right. Yeah. Thanks. So first of all, I'm going to address the anemia and the thrombocytosis. I think that's probably related to iron deficiency anemia, and I would not consider that a significant diagnostic player in this case. And yet she'll need that addressed when she's discharged. The sodium of 128 may be related to a cardiac source if she has evidence, other examination evidence like pedal edema or history of what might be congestive heart failure symptoms like general fatigue and malaise, like she complains of. And also, SIADH is very common in lung disease generally. So somebody with an infiltrate or pneumonia often has low sodium. This isn't a life-threatening sodium, so I think we can just tuck that to the back of our head and acknowledge it, and in the setting of her acute illness. The bigger things to me include her blood gas, and since you did give me some of this information before, I put what I think is a full blood gas together. So the pH being 7.25, her PCO2 was 77. I'm going to give her a PO2 of about 58 and her bicarb of about 34. It's a venous gas, so the CO2 might be a little bit elevated. Normal venous arterial to venous CO2 is 40 to 45, 40 on the arterial side and 45 on the venous side. So it's not a huge CO2 elevation. So this is a significant elevation of CO2. And I would say that if you correct the pH, I'm using a correction of with every 10 points of CO2, you see a change of 0.08 of pH, right? I can't remember all those other equations, but this one is quite helpful.
I was just saying it's really nice to hear that someone who sees these more than me feels the same way, because I can never keep these straight.
Well, it's very easy now with apps and everything just to look this stuff up, but I think this is a critical part of her case in that this corrects out to her CO2 being about 60 at baseline with a pH better, a calculated pH greater than 7.35 brings her CO2 down to about 60. And then her bicarb of 34. I mean, this shows that she's somebody that has a chronic hypercapnic state, essentially, or respiratory acidosis that's corrected. The one thing, then she has an acute respiratory acidosis, right, with her pH being down and her CO2 being elevated. So this would, for me, kind of suggest that she may be overweight and she may be a blue bloater, or somebody that is, just doesn't have CO2 or hypoxia response in their brainstem, and they just kind of don't care, in so many words, about what their CO2 and their O2 is doing.
I think that's our super helpful walkthrough of those labs and how you interpret them and how you sort of paint a picture, so to speak. I guess one question we should probably get to is, now that you're there with her and you're doing your exam, things like auscultation, point of care ultrasound, assessing the extremities and work of breathing. How do you sort of marry all of those skills together when you're doing your initial assessment?
Yeah, so this is something that brings out the experiential aspect of medicine. I think, I would walk into a room and kind of know in a second if someone, needed, where they needed to go in the hospital, if they needed non-invasive ventilation or mechanical ventilation. So to analyze that, I think I would look at their breathing first, and I would look for accessory muscle use. I would look for paradoxical breathing, chest down, abdomen up, abdomen down, chest up. And I would look at her eyes and see how distressed he or she is. And I would get a sense of what their work of breathing was based on that. I would see or decide if they were in respiratory distress, and with respiratory distress comes usually elevated work of breathing. For other exam, on physical exam, like I say, the auscultation would be important. I wouldn't really depend on a pulmonary auscultation exam would be important. I wouldn't depend that much on a cardiac auscultation. And I would want to know if they have pedal edema or not. And then also I'm, looking for if they're blue anywhere, lips, fingernail beds, etc. Echo, do you want me to go through that?
Of the work of breathing, especially signs, are there ones that you would treat are more concerning to you, where you triage to the unit maybe faster than where you're more comfortable with them being on the floor for at least a little bit? Can you kind of walk through that thought process?
Sure. Paradoxical breathing is threatening, but I would also ask her, if she's getting tired. And patients usually know exactly what's going on, and they often say, yes, I'm gonna crap out here. And so it's not necessarily just the exam, it's the discussion with the patient.
I interrupted before, so if you wanted to talk about echo and ultrasound, we could go back to it.
Oh, okay. All right. So bedside echo in this case might be helpful. We could get a sense of what her right ventricular appearance is, and I would be expecting if she did have right ventricular dilatation, then I would be even more inclined to get a chest CT angiogram Understanding also that somebody in acute distress may have pulmonary hypertension and acute right ventricular dilatation. I would get a sense of what their left ventricle looks like. And if they're at risk for left ventricular failure in the setting of right ventricular dilatation, which may contribute to pulmonary edema. And, we'd see any wall motion abnormalities. We'd see pericardial effusion. And then I would move to the lungs and look for evidence of pneumothorax, with the stratosphere appearance of bedside echo. I would look for B lines to see, to give us any sense if they have pulmonary edema or if they're developing acute lung injury. So that actually would be quite helpful in this, in kind of the early evaluation of her. And yet I still want the chest CT angiogram.
So I guess with that, we'll go ahead and say, okay, we're all signs at this point are leaving you with a leading diagnosis of COPD exacerbation. And so, we'll say that while she does look like she's having a little bit of difficulty breathing, after putting the oxygen on her, she is feeling better. She's starting to, feel a little more comfortable. You're not seeing that belly breathing. You're not seeing that tripoding or those retractions that would make you think, okay, this person needs to go to the intensive care unit for very close monitoring and potentially, impending intubation. So this is actually someone who we're going to say is appropriate for perhaps a progressive care unit for closer monitoring, but maybe not ICU level care.
Right.
And so as you're sort of putting in your admission orders and that sort of thing, I guess maybe before we get to the actual, like, what are you going to order and what kind of treatments are you going to administer? I did some research and did some reading, and obviously pulmonary fellowship's not too far away from me. Different people seem to have somewhat different definitions of what an acute exacerbation of COPD actually is. And so I was curious if you might have an operational definition for what constitutes an exacerbation to you. And then kind of a follow-up to that would be if there's a common pathophysiology that we should be familiar with in regards to those exacerbations.
What I've been telling patients, and I know my colleagues are, is that if they have a change from their baseline of shortness of breath, cough, or sputum, then, they're having an acute exacerbation of COPD. And by sputum, I mean, whether they have more sputum or purulent appearing sputum. And, and most frequently, this is something that occurs at home over a few days. And they, call clinic and we make decisions on whether we want to see them or, how to treat them over the phone. If someone has enough shortness of breath or cough or purulent secretions that would, require that they go to a hospital, that's considered a more severe exacerbation. And the gold guidelines allow stratification of COPD by greater than or equal to 2 exacerbations a year or 1 hospitalization.
So my other question was sort of like, having that sort of operational definition, basically increased dyspnea, increased cough, increased production of sputum, those sorts of things. Right. I think that's very helpful. But then is there sort of an underlying pathophysiology that sort of drives these exacerbations, something that, we as clinicians, our listeners, wherever they are in their training or in their lives, should sort of be aware of?
Yeah, things that precipitate acute exacerbations. So it's about a third viruses, a third bacteria. Somewhere in there we can include both because we know that viral illness is predisposed to bacterial pathology. but then, a third go undiagnosed, and we think that it's, exposure to external pollutants. But I would also suggest from our experience that GERD and aspiration are very important to think of, gastroesophageal reflux and aspiration. If someone has acute symptoms and a history of COPD, really acute symptoms, that's something to also think about. And once, if you think that the patient had GERD and aspiration, then, bacteria, either enteral bacteria or whatever she's colonized, or he or she is colonized with in their oral pharynx, may be helpful when you're choosing antibiotics. And I think of MRSA in this case. A certain number of people have oropharyngeal MRSA, or they're colonized with MRSA. And if somebody's aspirating and having exacerbations of their COPD, I think one would empirically want to include MRSA in your treatment. So that would be the precipitants of a COPD exacerbation. The physiology, I think, is really based on airway edema, and that there are many precipitants of changes in airway edema, and the airway edema is most likely at the small airway level, 2 millimeters or less. If somebody has bronchitis and worsening of their bronchitis, that usually suggests they have larger airway inflammatory changes. But the larger airway inflammation is an indicator of lower or smaller airway edema as well, usually.
So I think we've established a good sort of foundation in sort of the basics of history, labs, and then like what exactly is a COPD exacerbation. So the moment has arrived. I think it's a good time to maybe start talking a little bit about treatment. So I guess, we think about a lot of the mainstays, and I think the first thing a lot of us think about are the steroids. So kind of talk us through like dosing and choice and all that stuff. This
is still an issue that's up in the air, I think. I think most that are younger than I am use oral steroids in somebody who's admitted to a hospital. When it comes to, I'll back up a little bit, and when it comes to outpatient steroids, I think it's pretty clear. Steroids are beneficial. They diminish or they increase the time to the next exacerbation. They contribute to people's improvement initially, or faster. They limit failures to therapy. And so usually with any exacerbation, we use systemic steroids. Now, if somebody can't get systemic steroids, using inhaled budesonide has been shown to be helpful in this case. And the literature shows usually hospitalization, inhaled steroids or budesonide, and what's out there, they use nebulized budesonide up to about 4 milligrams, 4 to 8 milligrams, which if like usually we use 0.5 milligrams, 3 or 4 times a day for asthmatics, etc. So that's a lot of budesonide. But it's been shown to be helpful if somebody can't get systemic steroids. Now, in the hospitalized patient who is admitted with an acute exacerbation of COPD, I still think the way I read the literature and the way some of my colleagues read the literature, that we just, we're at an impasse, and there really has been no prospective randomized controlled trial comparing low-dose steroids to high-dose steroids, so that we are shackled with an inability to fully understand to give us this really good data. The last best data out there was from 2010. I think the author's name was Lindauer. He's a big data physician, researcher at Tufts in Boston. And he showed us that the conclusion from the paper was that oral systemic steroids are as good as high dose IV steroids. There is a lot of editorial concern about that conclusion. One of them is that nobody knew what the patient was like before they were admitted to the hospital. This was data that was gleaned from insurers and not from hospital charts. And the patients that were treated with prednisone were older, did not have private insurance, most of them, and it suggested that they may be of lower socioeconomic class, and it could be, my speculation is that they were hospitalized as if they were having an outpatient acute exacerbation, perhaps, because they didn't, their socioeconomic conditions, et cetera, didn't allow them to be treated at home. They were hospitalized, possibly. Now, the other thing is that many of these prednisone patients crossed over from the low-dose prednisone arm to the IV high-dose steroid arm, about 20% of them, 15 to 20%. And it was an intention to treat trial, and that wasn't taken into the final statistics. So I don't want to belabor it, but I think what I would choose is, what I have been doing is starting people on IV solumedrol, 60 milligrams, 2 to 3 times a day. Which comes close to overlapping with what's considered low-dose steroids, which is often 50 to 80 milligrams.
One of the questions that I think sometimes comes up for me is, for those who are maybe on the more severe spectrum of their underlying COPD, I think kind of classically we're all taught, 5 days burst steroids, and then they're done. But for those that either seem to have slower improvement, maybe because of the severity of their disease, I've heard rumors about maybe if they're like asthma, COPD overlap, you might consider tapering, but I don't know anything.
You went there with the taper,
I
girl.
did. I always wonder, my residents always ask, and I don't know what to do.
Neither do I.
Okay, cool.
So that's the answer. Well, so as the literature shows that 5 to 7 days, of the same dose, just burst of steroids, is not inferior to longer periods or tapering. And yet, this comes into some of the philosophy of medicine, is like how to look at what is a very good study and how that actually applies to an individual patient situations. The best studies are really valid relative to the subjects that they are studied in that paper, but they exclude so many people that it's sometimes hard to legitimately apply the conclusion from these good papers to an individual patient. And if they're not ready at 5 days, they're not ready. And you need to either continue your steroids or, attempt to taper, etc. So I would be with you on Meredith on, judging each individual patient based on their merits and etc.
Okay. Yeah, I think that's a pretty good overview of the steroids. I'm not sure I ever thought that hard about the studies that had been out. So I'm always glad to be reminded that you have to like put them in the context of the patients that like were studied, and then does that actually meet the patient you're treating? You know, the next piece is maybe just me being an ignorant hospitalist. And, you know, if someone's being admitted to the hospital for COPD exacerbation, I just assume they need to be on antibiotics. So please tell me I am right so that we can move on and then just be done with it.
Antibiotics in somebody with a severe COPD exacerbations are probably helpful. And, you know, the question is what kind of antibiotic to start. You know, you have your sputum cultures cooking, but you want to decide firstly, I think, on whether somebody's going to be colonized with Stenotrophomonas or Pseudomonas, et cetera. And those risk factors are out there if they have a previous culture. You know, if you do know the previous cultures and the patient has shown Pseudomonas, then you have to cover them for Pseudomonas. Other risks include if they have bronchiectasis, and if if they've received broad spectrum antibiotics within the last 3 months, they may be at risk both for Pseudomonas and MRSA. So those would go into your decision making. Let's say the patient doesn't have any of those risks for Pseudomonas, then you'd have to decide on an antibiotic regimen. A third generation cephalosporin is very good. Levaquin as a lung related fluoroquinolone is helpful. Moxifloxacin isn't used anywhere. Or I don't know if do y'all use moxifloxacin?
Not a ton, but some. Yeah.
At one of the previous cash locks I worked at, we did. So.
Okay. All right. Anyway, I haven't seen it used that much. And I don't know why we do this, but we often add azithromycin in, and I speculate that it's thought to perhaps have immune modulatory aspects to it, and not necessarily, broaden out the spectrum of an initial regimen with the third generation cephalosporin. But that's kind of how institutions and communities kind of gain a fingerprint of management. That's one of ours.
Ideally, yes. I think, getting culture results would be helpful. What happens in the situation where you either never get culture results to come back, and or you get a respiratory panel and that comes back? I guess start with the first one. You don't get culture results. What do I do with that, with a severe COPD exacerbation?
Oh, without you ever expecting to get cultures, I wouldn't be very worried about it. About 50% of individuals with pneumonia never grow out a known bug from their sputum, and that may be related to pneumococcus being difficult to grow out. But at least half, if not most, aren't going to give us an answer in the sputum culture. So we have to empirically treat or hone our antibiotics to the risk factors that the patient has, and wanting to be broad enough to limit the risk to those that have, severe COPD or comorbidities that are going to make them at high risk for mortality, age, which is a high risk for mortality. So you don't want to miss it, but you also, to be a good steward of antibiotics, don't want to be too broad. Does that get to the point, or? Oh, and then you had the respiratory panel.
Yeah.
Is that the viral panel you're talking about?
Yeah. So how does that play in? Say, maybe you don't get cultures back, but you do have this positive, pick virus NOS on your RSV. Your
What about
respiratory
influenza?
panel.
What do you think? That would be
Right.
really the only one that to me would make a difference.
So just to clarify, so like the reason you're saying it would be helpful to know about the specific virus is if there was treatment for it. But if you found out that it was another virus, would you ever peel off the antibiotics, or are you trying to get the anti-inflammatory effect from them that you would keep it on regardless of the viral panel?
No, there's a lot of co-infection.
Okay.
Because a classic presentation for pneumococcal pneumonia is somebody saying, I had this viral syndrome like a cold. Then the cold kind of went away, but then I got really sick 2 or 3 days after that. And that's like a classic bimodal presentation of someone with pneumococcal pneumonia. So I wouldn't. I would say I would think about it if somebody didn't have like grossly purulent secretions and we grew a virus out. I would think of stopping my antibiotics more so than if we had no microbiology information. But I wouldn't necessarily, on a uniform level, just stop antibiotics.
Okay. So then I think the other mainstay of treatment that a lot of us think about are bronchodilators. So do you want to just start by walking us through what kind of dose, treatment, all that good stuff?
Yeah. So someone who's hospitalized, we want to start short-acting bronchodilators. We usually do both of them. And none of this is based on any data, really. There's not great high-grade data for short-acting bronchodilators, but they seem to help. So we use them. In the outpatient setting, we use short-acting bronchodilators as kind of an indicator of whether somebody is becoming more short of breath or not. So I ask patients to tell me how frequently they're using their LABA or their LAMA, because I use that as an indicator of where their COPD is going.
Do you mean their SABA or their SAMA?
Oh, sorry. The short-acting bronchodilators, yes, not the long-acting. So the albuterol use or ipratropium use, if it starts increasing in frequency, then I have some idea that they're more short of breath, and I may be prone to treat them as if they're having kind of a slow burn of an acute or of an exacerbation of COPD. When it comes to long-acting bronchodilators, I think the GOLD criteria spells it out pretty well. And if we're going to pick one to use, it would be a LAMA over a LABA or LAMA-LABA for GOLD 3 or GOLD 4 patients. The LAMA seems to have a better track record with limiting exacerbations, etc.
What do you do with their home inhalers? Do you just hold them?
I do. I would want to see them on a LAMA and LABA in the hospital. Certainly, if their home meds include that, even if they don't include that. But how they're delivered. Usually, I'd like to see them delivered through nebulizer in the hospital. And, that's addressing this issue of whether an MDI is as helpful as a nebulizer. Yes, in the outpatient setting, the literature shows they're equivalent in medication delivery. But in a patient who is maybe a little delirious, they're very short of breath, they're maybe not that cooperative with an MDI system, I would like to see them on a nebulizer.
Okay, so I think that that's a great overview of steroids, antibiotics, and bronchodilators, which I think are all mainstays of therapy. But with the time we have left, obviously being respectful of your time, Jim, I do want to talk about a couple other things, in particular, oxygen therapy. And so obviously there's an array of options that we can use. But I'm particularly interested in how you use PAP therapy, whether it be continuous or bi-level, and how you sort of how you apply that on the inpatient setting. Who are your candidates for PAP therapy? What are your endpoints? That sort of thing. So maybe you could walk us through your process.
Sure. So first of all, I think you need to give enough oxygen for the patient to survive. And one of the reasons I say that is because it sometimes can be mistaken that, by giving oxygen, you may contribute to hypercapnia, which may be true, but you also need to give enough oxygen for the patient to survive. So you do want to target a goal of 88 to 94%, let's say. You don't want to go above that because of the Haldane effect and, ventilation and perfusion mismatching issues. So that given, that there's enough oxygen. The second thing that you didn't mention, Cyrus, and I want to add, is heated high flow.
Yes, huge fan.
Oxygen.
Thank you. Yes.
Yeah, because that's been shown to be quite helpful. It allows for higher flow for O2 that, where patients need higher FiO2 or O2 flow. But also it does actually diminish work of breathing, and it does that probably by pressurizing the airways, by about 5 to 10 centimeters of H2O, and it's quite helpful. And also it limits. I don't know the mechanism behind this, but it's actually, it's been shown in some correlative studies that it limits readmission. So it's a good thing to use on the floor. When it comes to PAP therapy, I think there are some things that one wants to pay attention to try to prevent somebody from needing the ICU. One of them is certainly if they're complaining of being tired or short of breath and tired of breathing, probably need the ICU. Maybe would do okay on a step-down unit with BiPAP or CPAP. But then others, hypercapnia, respiratory acidosis, just as treatment of COPD. So this isn't necessarily on the respiratory side. We know that people with COPD who get non-invasive partial pressure ventilation actually do better. So it's kind of a treatment as well in the COPD setting. They get out of the hospital earlier, they feel better, they turn around better. I'll say this, even CPAP can diminish work of breathing and be helpful in patients with acute exacerbations of COPD. Most of the studies have been done with BiPAP or a volume targeted PAP of some kind. But if you can imagine this, somebody having air trapping and their alveolar pressure at the end of exhalation is about, let's say, plus 10 centimeters of water. They have to generate negative 11 centimeters of water to get any movement of air into their lungs. If you put a CPAP mask on them and you match that end expiratory pressure at the alveolar level with CPAP, that means they have to pull -1 centimeter of pressure to get movement of air. So that essentially diminishes work of breathing significantly. And CPAP can sometimes be easier for a patient to sync with as opposed to BiPAP. But in the end, it's if you're going to choose one or the other, I'd probably choose BiPAP. But I wanted to go through the CPAP thing.
I think that's helpful because we often don't think about, we think of, like, I think a lot of folks are dogmatic in that it's like, okay, we're going to use CPAP for heart failure. We're going to use bi-level for COPD because of the delta P, if you will. And so I think it's helpful to look at it from that perspective. And the other thing that I want to make sure that we're clear on is really the purposes of in this case, let's say bi-level therapy, is to decrease work of breathing, enhance minute ventilation, and then hopefully by doing so, improve that acute hypercapnia. Is that like a fair statement?
Yeah. No, and the delta P will help with the minute ventilation, which will help blow off more CO2. The CPAP part of that is the one that diminishes the work of breathing, which then diminishes the generation of CO2. So by using BiPAP, yes, you can use both of them.
And just for maybe
mechanisms
to be clear, when I talk about delta P, or we talk about delta P, we're talking about that end expiratory pressure, so that baseline pressure, and then your inspiratory pressure is going to be higher than that, resulting in a quote unquote delta P. So just for the sake of clarity, I guess it probably would be helpful, since we're talking about a patient in the progressive care unit, is there something in particular you look at when you have a patient on, let's say, bi-level, and you're sort of worried, like, okay, this could go one way or the other, in regards to mechanical ventilation, invasive ventilation versus, okay, this person's going to get better? Is there a time course that you're like, okay, I'm going to give this person 2 hours, and after 2 hours, like, that's that? What's your sort of, I guess, end point of treatment for bi-level on the inpatient side?
Good question. So I would work with the respiratory therapist to start BiPAP. And the one thing I would be most mindful of at that time would be their anxiety, their ability to synchronize with the BiPAP, because that's frequently a hurdle, right? And we're not really equipped on the step-down units for the amount of sedation that we can give somebody, on the ICU. But it may help to in trying to avoid benzodiazepines, or minimizing benzodiazepines to help the patient with sedation a bit. That would be the first thing. And then as I'm moving through the hours, at about an hour or two, I would want to check their arterial blood gas, or a venous blood gas. And I would want to know that it's trending the right way, or at least staying the same and not worsening. If it is worsening at that point, I would just, and it is like an hour or two, I wouldn't let them languish overnight without, reevaluating their acid base status and their CO2 and their O2 status. When I'm thinking that I have to make a decision on whether they go into the unit or not.
Thank you. I think that's very helpful. I don't know if, I think that's what I've typically done too, when I'm like either consulting on the inpatient side, or when I'm doing internal medicine, is like an hour or 2 hours, and you either kind of buy yourself endotracheal intubation, or you're moving in the right direction. Sort of along those lines, as we move towards discharge, let's say we're getting, towards the end of the hospitalization, things have gone well, we're getting ready to send our patient home. I know that Meredith and Moni are going to talk about some pearls here, but I was curious, there is some data, conflicting data regarding PAP therapy or specifically bilevel therapy on discharge, and how effective it can be in preventing hospitalizations or recurrent hospitalizations. So I was wondering if you could speak to kind of, let's say, non-invasive ventilation post COPD exacerbation, what your thoughts are on it. And then if we're able to use it, what should the goal be? What are we trying to accomplish? Are we trying to normalize the bicarb? Are we just trying to, make them feel better? How do you approach that?
There is a suggestion that there is benefit after hospitalization. With newer literature, the older literature they didn't really show the positive effect of diminishing CO2 and diminishing readmission for COPD exacerbations when patients who need it or qualify medically to get NIV at their home. There are home problems as well, and this goes into the socioeconomic aspects of COPD exacerbations and who gets them. Usually it's lower socioeconomic, or often lower socioeconomic patients. For many reasons, they develop acute exacerbations. And in this case, one of those might be there's not great home accommodation for having a complicated machine to help a patient with doing something at home that we've been taking care of in the hospital. They may not have the family or friend support or the social support. Often it's difficult to transition somebody to a skilled nursing facility or a rehab center with non-invasive ventilation. So I don't have a clear answer for this. I think it really is kind of a social problem with medicine vis-a-vis our COPD patients and patients who have acute exacerbations of COPD. It's a hole in our coverage.
Yeah, I think it's a good reminder too, sometimes the difference between what you practically want to do and what you are able to do with the resources provided in the system.
Before we kind of move on, let's suppose it's a kind of different patient. They have private insurance, gold plated, platinum plated. Here is your ventilator at home. Now I'm the friendly neighborhood internist or pulmonologist, let's say, that's managing it on the back end. What am I looking for? What are we trying to achieve?
So I would say we're trying over the long run to work on somebody's CO2. So like you say, Cyrus, their bicarb will change, and that will give us the confidence that we're being successful with that intervention. What I do believe there is a signal for as well is that it will limit the risk for readmission for COPD, and that seems to be what we all are looking at. And then finally, it will, in a broad sense, probably make the patient feel better.
Thank you. That's helpful. I appreciate that.
So I guess along those lines, I think one of the things that I often get caught up in also as you're approaching discharge is who should that patient follow up with? Specifically, I feel like I feel bad referring everyone to pulmonology. But then I'm also like, you were just hospitalized with pretty significant COPD. So who should, see pulm? Who should follow up with their primary care? What does that timeline look like? Or is it both?
What I would say is it would be very reasonable, and we actually want to see this where I practice, that we see the patient as a pulmonary group within 2 to 4 weeks after discharge. And then, we would make adjustments, make recommendations for follow-up with us, but then, hopefully kind of coax the patient back to their primary care physician. The most risky part for a patient is about 4 weeks out from discharge, and early follow-up is probably the most significant intervention. In some cases, pulmonary rehab may be helpful after discharge, but I think the literature is still, a little iffy on that. We're actually trying to, contribute to the literature in that regard.
I think in the interest of making sure that we all get to sleep at some point this evening, why don't we just, I think it'd be good to kind of just do some take-home points, because I think we've covered a lot of ground that's been great, but just maybe 3 take-home points that you would want us to take away at the end of this.
Oh, okay. I would say that prevention is very important and education is important. And so, we kind of put prevention towards the end, and it may be more effective towards the beginning, when we're talking to our patients in the office, talking about smoking, talking about use of inhalers and appropriate, effective use of inhalers, the right inhalers, and then how to try to jigger our ability to kind of limit their risk for exacerbations based on the GOLD guidelines. Secondly, when it comes to hospitalizations, look for PE. I think that's a pretty common thing that sends an older former smoker with comorbidities into the hospital with an acute exacerbation of COPD. When admitting them, broad spectrum antibiotics, keep in mind Pseudomonas and MRSA, and risk for colonization. If that risk exists, then we want to cover the patient initially with antibiotics that would cover those bugs. When it comes to systemic steroids, I think there is still what we call equipoise out there, right? Where we don't know exactly, where to land on the steroid issue. That we do know that people do better with systemic steroids when they're hospitalized as opposed to placebo. It's just the dosing. We've seen a trend in dosing in 40 to 80 milligrams a day, which it would be lower dose. Some of us, including myself, think perhaps that higher dose may be more effective, yet there is risk for diabetes and suppression of inflammatory processes and things like that. So we still don't know. We don't know. And on discharge, low threshold for non-invasive ventilation if people meet criteria. Frequently, it's if they present with a PCO2 of 45 or greater. In some of the test literature, I believe that Medicare is reimbursing with 52 centimeters of water or greater. One would have to check that with their local Medicare system, since each state is a little bit different.
And we will be back with our lightning round.
We're going to just start by getting to know you a little bit. So would you mind starting with your one-liner?
You got it. So I'm a 62-year-old physician who loves medicine, seeing patients, and enjoy my family and friends. And also I've been quite a traveler through my life, and just recently got a master's degree in the philosophy of medicine at King's College in London.
Man, that's like taking that whole lifelong learner thing to the next level, I have to say.
Yeah, I'm never going to quit.
What's next then?
I don't know, actually. I think staying at work for a while.
All right. Well, I guess with the lifelong learning mentality, do you have any favorite like advice or feedback that you've ever gotten from someone during your training or career?
First of all, I've gotten a lot of advice, and most of it has been very helpful. But one that sticks out is from an attending I worked with when I was a resident, who just said, never forget about the patient. And I think that's important, has been to me, because through my career, and I know others will encounter this, that, academic pressures, social, economic pressures can take your mind off what we're really there for, which is the patient.
Wonderful advice. I love it. That's usually my guiding principle too, so I support it. I think just for sake of time, and because Moni and I have been hanging on to this pick of the week for a while, we're going to jump to pick of the weeks.
Meredith, it's all you this week.
It is.
Please tell. This is so good, and we're going to definitely have a link for this one.
Yeah, so we'll put the link in the show notes. I don't know if actually Cyrus and I were talking about this a little bit before I aired that I'm from Texas. And I don't know if anyone's had the extreme pleasure of watching the Officer Big B Fort Worth Police Department recruiting video. I don't know if either of you guys have, but it's fabulous. It is one of the funniest things I have seen in a long time. They essentially spoofed like a used car salesman commercial, and
complete with neon chyrons.
Yeah, and like people pretending to be the like balloon people that go up and down. This is going to be great on video, I just realized. Up and down. And so Moni and I were having like a very bizarre day at work, and I just had seen it the night before, and so we were watching it like on repeat for a full day. So it's brought much joy to us, and we'll put in the show notes for everyone else too.
And because it hasn't happened in a while, I will point out that this is so viral that Kelly Clarkson talked about it on our talk show. I just have to say.
And it wouldn't be a complete show tonight if we didn't reference Kelly Clarkson at least once.
Because it's been a few episodes. I've been pretty good about it, I have to say.
Yeah.
Okay, enough of that. Cyrus, do you have a pick of the week for us?
Picks of the week. Oh, man. Yeah, I have a lot. Well, I guess on the heels of taking the critical care boards yesterday, that was probably one of the most painful experiences of my life. I'm enjoying an adult beverage, a High Noon. Big fan. Drink responsibly, drink in moderation, please, guests and listeners. But I feel like I earned it after going through the pain and suffering that was the 10-hour ordeal of the critical care boards, which I could just go on and on and on about the experience, but I will spare everyone that. And then I guess if I can throw in a bonus pick of the week, I did take some time to do some pleasure reading, which I haven't had a lot of time for recently. And I'm a big music person. I'm a big Chili Peppers fan, and I actually got to see them at ACL this past time. And prior to that, I read Anthony Kiedis's Scar Tissue, his autobiography, which is it is a true miracle that man is still alive. That's all I can say. Worth the read if you like the Chili Peppers.
For sure. I saw them live a few years ago and remember thinking, I think maybe the touring thing maybe should slow a little bit for y'all.
It's crazy. It is crazy. What an insane life that man has had. And again, just like the fact that he is still alive is mind blowing. But there you go.
I'm pretty sure.
The human body is tremendously resilient.
So this has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Yummy.
It's great. That was excellent. Get show notes at thecurbsiders.com and sign up for our mailing list to get our weekly show notes in your inbox. Plus, twice each month, you'll get our Curbsiders Digest, recapping the latest practice-changing articles, guidelines, and news in internal medicine.
And we're committed to providing high-value, practice-changing knowledge. And to do that, we need your feedback. So please subscribe, rate, and review the show on Apple Podcasts or Spotify, or email us at askcurbsiders@gmail.com. A reminder that this and most episodes are available for free CME credit for all healthcare professionals through VCU Health at curbsiders.vcuhealth.org. Special thanks to our writer-producer today, Dr. Cyrus Askin, and to our whole team. The Curbsiders is produced and edited by the team at Podpaste. Elizabeth Proto runs our social media, and Stuart Brigham composed our theme music. And until next time, I've been Dr. Moni, not Money, Amin.
And I've been, and hopefully will continue to be, Dr. Cyrus Askin.
And as always, this has been Dr. Meredith Trubit. Thank you and good night.